So obviously this involves participation, so I'll be looking out for your answers. Please try and be quick so that we don't waste time in silence. Okay. So first question shows you a series of pictures of children. So what condition do these children have? What condition do these children have? Anybody in the audience? Fantastic, good. So they have Williams syndrome. So which chromosome does Williams syndrome affect? Fantastic. So normally this is a sporadic type defect, although it can be autosomal dominant. Now the facies in Williams syndrome is quite typical. Can somebody describe the facies of these children? What is the name given to facies of Williams syndrome patients? Correct. So they have elfin-like faces. So they have quite a pointy chin. They have a wide mouth. And what ophthalmological abnormality can they have? What can you see in their eyes? What feature can you find in their eyes? Any ideas? Any answers? So they can have stellate irises. Okay, so you know, specific pattern in the iris, which I'm sure if you look up in a textbook you will find. So they have stellate irises. So we've already gone through this. Right. So on the same theme, what are some of the features of Williams syndrome? So we know we've talked about the facial appearance. What are the other features of Williams syndrome? Answers? Okay. Okay. Right. So I've had some cardiological, very good. So the hypercalcemia, I think is what you meant. So hypercalcemia is one of the features. And then you can have cardiac abnormalities as well and renal abnormalities. And they can have, you know, developmental delay. Hypertension, correct. So they can have renovascular abnormalities. So there can be an arteriopathy. Yes. They have a cocktail personality or a friendly nature. So these children are a delight to treat. Okay, shall we try and look at the answers so that we see if we have covered everything? Cocktail personality, the facies. We've talked about the various facial features. Wonderful. We've covered most of it. Only thing that we've missed out is a dental abnormality. So they have bad teeth. Now, if you remember the previous picture, you know, the one of the children, you could clearly see that he had bad teeth. So, correct. So, you know, dental abnormalities are the other feature. So, we spoke about the cardiovascular abnormalities. So, already you've given me some answers. So, the question is, what are the cardiovascular abnormalities associated with Williams syndrome? So, I've already got supravalvular aortic stenosis, which is perhaps the most common. Now, 80 to 90% of children with Williams syndrome have cardiovascular abnormalities. So it is important to screen these children for cardiac problems. You can have branch pulmonary artery stenosis. You can have supra-PS as well, supravalvular pulmonary stenosis as well. You can have renal stenosis. What other problem can these children have related to the heart? What is the other abnormality that they can have? Okay, I'll give you a clue. It's related to the supravalvular AS. I'm not so sure that vascular dilatation is a feature of Williams. These children actually have arteriopathies with stenosis. So I'm not sure if that answer is correct, the vascular dilation answer. Due to hypertension, okay. But what is the other feature which is closely associated with the supra AS? What else can get affected? What else is in that area? It's fairly simple. Coronary artery stenosis. So because the coronaries are in the same region, plus in addition, children are hypertensive, so they can develop coronary artery disease. Yeah, they have accelerated atherosclerosis as well. So these are some of the other vascular features. So let's see if we've got all of them now. So we talked about supra AS, peripheral PS, supra PS, valvular PS as well. Coarctation. Coarctation is the other abnormality that these children can have. Okay. Next is a true or false type answer. Supravalvular PS in Williams can regress with time. Is that true or false? Can it get better with time? That's correct. Okay. So supra PS can get better with time, whereas supra AS tends to get worse. So it tends to progress. Fine. Right. Now we move on from Williams syndrome. So what condition do these children have? You have two images there. What condition do you think these children have? Fantastic. So this is DiGeorge syndrome. Can you describe the facial features to me? What are the characteristic facial features of these children? Right. Okay. Correct. Correct. Fantastic. So I think you've covered all the features. So let me just read them out. So one, you can notice the widely spaced eyes, depressed nasal bridge, the small mouth, slightly pinched nose, low set ears. So these are all the various features that are characteristic. You can see it in this child as well. The ears are quite low set, the nose bridge is quite wide, and the nose appears pinched, and the eyes are widely set. So this is DiGeorge syndrome, which, as you know, is quite common amongst our patients. So what are the other components of DiGeorge syndrome? What are the components of DiGeorge syndrome? What is the other name given to DiGeorge syndrome? Okay, catch-22. So that catch-22 helps you list out the features. So it's actually an abbreviation. So can you tell me some of the features of DiGeorge syndrome? Right, it's deletion 22q11, that is correct. But what are the components? What are the various features of DiGeorge syndrome? So we looked at the abnormal facial features. What other features does DiGeorge have? Okay, so cardiac abnormalities. The A stands for abnormal facies. The T stands for thymic hypoplasia. Somebody's mentioned. The other C, what does it stand for? What does the C stand for? Okay, the H is hypocalcemia. We have one C that is not accounted for. Correct, absolutely. So these are some of the features. In addition to that, you can have developmental delay, learning difficulties. You can have renal abnormalities. So these are the other components of DiGeorge syndrome, or other features of DiGeorge syndrome. Oops, sorry, let me go back. Right. we've covered all the various features that we wanted to cover. So how can DiGeorge syndrome be definitively diagnosed? Of course, you look at the patient, you think they have DiGeorge. What are the tests that you do? FISH test. Can you expand what FISH stands for? What does FISH stand for? It's a long set of words you have to correct. Fluorescent in situ hybridization. So that that is a specific genetic testing that you need to do in order to pick up DiGeorge. And you've already mentioned what the genetic abnormality is. And this is DiGeorge, interestingly, is the most common deletion syndrome known to us. Okay. Now, what is the incidence of congenital heart disease in patients with DiGeorge in reported series? And what are the common abnormalities? So these are the two questions that we need to answer. Okay. Okay. It's actually in some series it's reported to be higher. The problem, of course, is so it's at least around 50%. The problem, of course, is DiGeorge is highly undetected in general population. So some series have reported 70 to 80% congenital heart defect in patients with DiGeorge. But because the features can be subtle, sometimes patients don't get picked up into adulthood. So maybe only the patients with congenital heart disease get picked up early because of the cardiac symptoms. So yes, we expect that the incidence is actually less than 70 to 80%. So maybe around 40–50% is not an unrealistic estimate. But it's a highly variable number, and that is the problem with most of these series of patients, that they are highly selective and there is a selection bias in these series. But if you're going to follow Moss and Adams as your textbook of choice, then it's 70 to 80%. Now, when we talk about the common abnormalities, everybody has talked about TAW, truncus, and interrupted aortic arch. Now, the important thing to mention is arch anomalies are quite significantly associated with DiGeorge syndrome. So you shouldn't forget arch abnormalities like double aortic arch or abnormal aberrant takeoff of the subclavian artery. These actually are quite significantly linked with DiGeorge syndrome. And what type of VSD? When we say VSD in relation to DiGeorge syndrome, what type of VSD is specifically related? Any answers? Correct. So it's mainly outlet and perimembranous VSDs, predominantly perimembranous VSDs. Okay, this is a true or false question. Patients with absent pulmonary valve syndrome have a higher incidence of DiGeorge syndrome than standard TOF patients. Is that true or false? Okay, right. I have one false and one true, and the right answer is true. So if you look at the incidence of DiGeorge syndrome in standard TOF patients is about 15–20%, whereas if you have absent pulmonary valve syndrome, the incidence is up to 40%. So patients with absent pulmonary valve syndrome do have a higher incidence of DiGeorge syndrome. Okay, another question. What is the incidence of DiGeorge syndrome in patients with a perimembranous VSD with and without an arch anomaly? So we talked about arch anomalies and how they were related to DiGeorge syndrome. But do you know, if I gave you a group of patients with just plain perimembranous VSD, how many of them will have DiGeorge syndrome? And if I gave you a group of patients with perimembranous VSD associated with an arch abnormality, then how many of them would have DiGeorge syndrome? Right. It's not too bad. So the numbers that are widely quoted are, if you have just a perimembranous VSD, it is less than 5%. It's about 3–4%. Whereas if you have an arch anomaly, this goes up significantly to about 45%. So there is a significant association with of DiGeorge with arch anomalies. What percentage of DiGeorge syndrome is familiar? So how, what percentage of DiGeorge patients actually runs in the family? Any answers? Is it 50%, 25%, or 10%? I've given you 3 choices. Correct. So it's around 10%. And like we said, it's the most common deletion syndrome. Okay, we move on from DiGeorge now. So what disorder do these children have? Fantastic. So they're very nice pictures really, and giving you a group of pictures helps you because it highlights various features of the syndrome. So can you tell me what are the features of Turner syndrome? What are the common features of Turner syndrome? Okay. Okay. So it's useful when you're asked these sort of questions to slightly classify things in your mind. Okay. So you can classify them into perhaps external appearance. Okay. I'm getting lots of answers. I'll read out some to you. So web neck, widely spaced nipples, and a shield-like chest. We saw that very nicely in this previous child, in the previous slide. Also, you can have cubitus valgus, which is, the forearm is angled outwards. In the neonatal period, you have lymphedema of the feet. You can have cystic hygroma, which is seen behind the neck. Then increased carrying angle, that's right. Then you can have short stature. You have hearing abnormalities. I don't think anybody's mentioned hearing abnormalities. So if you have a patient with Turner's, a baby with Turner's, you have to get their hearing checked. So that's important. And you can have infertility, of course. So these women will be infertile, and the damage to the ovary starts right from birth. Correct, hypogonadism. Can you tell me what is the most common presentation of Turner syndrome? What is the most common presentation of Turner syndrome? We've talked about various presentations, but what is the most common presentation? Okay, it's a trick question. If you actually see, the most common presentation of Turner syndrome is actually an aborted hydropic fetus. So quite a few of these Turner syndrome babies never make it to birth. But yes, in the postnatal period, perhaps short stature would be the trigger. Once again, it depends on how well short stature is investigated. But actually, the most common presenting feature is in fetal life as an aborted hydropic fetus. We've missed out horseshoe kidney, haven't we? So that is again, a feature of Turner. So if you have a patient with Turner's, hearing test, abdominal ultrasound, both important. Okay. Right. So what is the incidence of congenital heart disease in Turner syndrome? So we said in DiGeorge syndrome, it's probably around 50%. Again, varies, between series. Yeah, correct. So it's about 30%. So 20 to 30% is not a bad answer. What are the common cardiac abnormalities? Right. So left-sided abnormalities. So Turner syndrome has a predilection for left-sided abnormalities. So we start with, okay, bicuspid aortic valve, aortic stenosis, coarctation of aorta. What else can you have? Mitral valve abnormalities, perhaps? Correct. Mitral valve abnormalities. What is the other fairly important cardiovascular feature? Partial normal coronary venous connection is correct. What is the other important cardiovascular feature which needs monitoring Okay, this is something that you would particularly be concerned about. Say you have a Turner's patient with coarctation. What are you worried about? You have a patient with Turner's and coarctation. I'm telling you, a 12-year-old patient, severe coarctation, Turner syndrome. Correct. So aortic root dilatation and dissection is what I was trying to get at. So in a patient with Turner syndrome, if you're going to implant a stent, say for coarctation, you would prefer to go for a covered stent. Say you are in a resource limited situation and covered stents are too expensive, then at least you will have that covered stent as backup in your lab, which ideally you should do for all cases, but sometimes we work in less than ideal situations. But you should have that covered stent as backup. You should have blood cross-matched and ready. So you have to take much more care in this patient than in any other standard coarctation patient. And perhaps if you had a very tight coarctation, you would do graded inflation. So dilate the stent up to a certain level initially, and then perhaps bring the patient back later on to redo the dilatation and not be too aggressive with your dilatation. Okay, so we move on from Turner. So what do these children have? Okay, see the ptosis is a giveaway, isn't it? So yes, these are very nice typical photos of Noonan syndrome. Tell me, what is the mode of inheritance of Noonan syndrome? Correct, it can be autosomal dominant, but actually often it is sporadic. Correct. So it can be autosomal dominant, but more commonly it's sporadic. What are the most common heart defects that are associated with Noonan syndrome? Okay. So PS, valve PS itself is very common, isn't it? The dysplastic pulmonary valve, which you find very difficult to balloon dilate, it's typical of Noonan syndrome. Of course, you can have supravalvular PS, which is often closely associated with the valve. You can have peripheral PS. Hokum is right. So these are some of the features. And 80 to 90% have congenital heart disease. So quite just like we saw with Williams syndrome, quite a high percentage. The other condition which is closely associated is Hokum. Hokum you have mentioned. So apart from that, of course, the usual ASD, VSD talk. Coarctation, again, both Noonan's and Turner's can be associated with coarctation. So sort of easy for you to remember. And both of them can be associated with hypertrophic cardiomyopathy. So what other syndrome has phenotypical abnormalities with Noonan syndrome? Of course, leave alone Turner's, but what other, it's quite, MPS, okay. Any other syndrome that you know of? Just quite similar to Noonan's in terms of appearance. Allergiles, some of the features, they're not totally similar. I can see why you're saying allergiles, but I'm talking about feature similarity, not correct. Leopard syndrome, that's what I've been trying to get at. So it's a neurolentiginous syndrome or Leopard syndrome that is quite similar to Noonan syndrome and can be confused with Noonan syndrome. Okay, what are the syndromes that are commonly associated with peripheral PS? This may be a repetition of things we've already discussed, but if I asked you the question, what are the syndromes? Correct. Williams and Allergies, that is perfect. Those are perhaps the most common. Noonan's, more commonly, it's valvular pulmonary stenosis. The hallmark feature of peripheral pulmonary stenosis. Okay, congenital rubella is a good point. I didn't mention genetic syndrome, so correct. Congenital rubella is very much on the spot. So allergies, Williams, and congenital rubella if you take a non-genetic syndrome. What is the most common mutation of Alagille syndrome? What is the name of the most common mutation of Alagille syndrome? Any answers? There's prolonged silence on the airwaves. Am I to assume that nobody knows? Okay, fine. So it's called the JAG1 mutation. I think it is quite, widely known. But this is the mutation that is typically the problem in Alagille syndrome. So we obviously we've been talking about Alagille syndrome. What are the features of Alagille syndrome? We know that one of the features is peripheral PS. What are the other features of Alagille syndrome? Non-cardiac, biliary, correct. So cholestatic jaundice, biliary atresia. Vertebral anomalies, good. Facial features, so typical facial features, you have a broad forehead. Any other abnormalities? Any eye abnormalities? Yes, what is the eye abnormality called? Correct, posterior embryotoxon. So you will send this patient to the ophthalmologist so that they can have a look and tell you if there is a posterior embryotoxon or not. So I think we've covered most of the stuff that we wanted to talk about. So pulmonary stenosis, peripheral pulmonary stenosis, and bleeding tendency. So these children can have tendency to bleed. Okay. So what condition does this child have? We're sticking on a genetic theme for the moment. What condition does this child have? Very good, Holt Oram. Okay. So this is characterized by skeletal limb abnormalities, and the typical feature, the pathognomic feature, is the radial hypoplasia or aplasia. They can have just triphalangeate appearance, absent thumb, so this child doesn't have a thumb, and you see that there is radial hypoplasia. Along with that, you have complete heart block. So complete heart block is associated with this syndrome. What are the other structural abnormalities that are commonly associated with this syndrome? Correct, ASD is strongly associated. And what else? Although ASD is the more commonly associated, VSDs are also associated. And what type of VSD here? Any ideas? What type of VSD is commonly associated with Holt Oram? Okay, it's muscular. It's muscular VSDs that are more commonly associated. All the VSDs have come up now. So it's not really an inlet VSD, but it's muscular VSDs that are associated with this syndrome. Okay, now we're moving on to a slightly different topic. What is a typical type of hypertrophy that you see in hypertrophic cardiomyopathy? Asymmetric septal. Okay, fine. So, good. Now, can you answer this true or false question? Asymmetric hypertrophy only affects the septum. Correct. Quick answer has come through, which is false. Yes. So it can affect. So just most people talk about asymmetric septal hypertrophy, but I put this question in just to clarify the point that it's not just restricted to the septum. Although it's very commonly found affecting the septum, this can happen in any part of the ventricle. So what is the specific type of cardiomyopathy that is commonly seen in Japan? Yeah, which is the apical cardiomyopathy. Apical cardiomyopathy is the answer. that I was looking for. But yes, so it's very difficult to detect, and has to be looked for very carefully. When is the highest rate of progression of HCM? Is it in infancy, childhood, adolescence, or late adulthood? That's correct. So the answer is actually adolescence and early adulthood. So this is when this is the time of maximum growth of the individual that actually you see the highest rate of progression. So which is why when you suspect, when there is a family history of HCM, you cannot just look at the patient just once during childhood and discharge them from follow-up. They need to be screened until you are confident that they have reached adulthood and they don't show any signs of HCM. We'll come to this particular topic in a bit. But the other point to make is that although yes, we look at echo to look for asymmetric hypertrophy, ECG often shows the earliest signs of HCM. So what are the ECG findings which would make you worry about HCM? Correct. LVH and strain pattern. Yeah, correct. T-wave inversions and LVH type pattern. Okay, what is the mode of transmission of hypertrophic cardiomyopathy? And what are the most common genes? There are lots of genes that are associated, but can you name maybe the two most common genes that are associated? Yeah, autosomal dominant is totally correct. Right, I've got one gene, beta myosin heavy chain. The other one? So these are the two genes of beta myosin heavy chain and the myosin binding protein C. So these are the two genes that are most commonly associated with hypertrophic cardiomyopathy. So how would you screen patients, if you have somebody in the family with hypertrophic cardiomyopathy, established hypertrophic cardiomyopathy, how would you screen with ECG and echo? Fine, fantastic. What sort of intervals would you screen them at? I've told you already that doing it just once is not enough. So how often would you see them? Yearly. Okay, is this for the rest of their life? Yearly till adolescence. Okay. Any more answers? So I have one yearly, which I presume is forever. I have another yearly till adolescence. Any other answers? Okay, so actually during childhood, we don't have any clear ideas as to how often to screen. So because the pickup rate, because the progression of the disease happens around adolescence and adulthood, the pickup rate of problems during childhood is not that high. So perhaps doing it not necessarily on an annual basis, but maybe doing it every 2 years or 2 to 3 years may not be a bad idea. For example, if you start screening the child at the age of 2 years, they have a history of family history of HCM, you start screening them at the age of 2 years, then screening them annually can be a bit of a bother. So maybe until they reach the age of 10 or 12, you can screen them less frequently. But once they come into the adolescent period, I agree, you have to screen them yearly. And then again, you screen them like this until they get to their 20s perhaps, early 20s, and the heart is still normal. Then what do? Do you stop screening them? What is the current recommendation? Any ideas? Yeah, at least 5 yearly. So you have to continue to screen them, and this is because there is a subgroup that presents very late in adult life. So you have to continue to screen them, even though you may not have found anything. So this is the broad recommendation. Obviously, everybody has their own way of doing it, but this is the broad recommendation. So what are the risk factors associated with sudden death in HCM, which will make you consider perhaps an ICD implant? What are the risk factors? Okay, arrhythmia, what does that mean? I have atrial ectopics. It's not a very specific answer. Okay, ill-sustained VT, that's right. So get the big ones first, okay? So if I have a cardiac arrest, I have HCM, and I have a cardiac arrest or VT, which needs shocking, then that would put me in the high risk category, okay? Then you have non-sustained VT, which could be, you holter these patients often, particularly the ones with severe HCM, you holter them, and on the holter you say non-sustained VT. That does increase your risk of sudden death. What are the other factors? Does it matter, the degree of hypertrophy? Does the extent of ventricular hypertrophy matter? Okay, history of syncope is a risk factor. LVOT obstruction per se isn't actually. LVOT obstruction per se isn't. What is a wall thickness greater than 3 centimeters. So this has been found to be related with a wall thickness that is greater than 3 centimeters is related to sudden cardiac death and family history of sudden death. So these are the various factors that would indicate high risk. A poor blood pressure response and exercise is also a risk factor, but the main risk factors are previous cardiac arrest or VT, family history of sudden death, hypertrophy with wall thickness greater than 3 centimeters, and history of syncope. In addition to that, you can add non-sustained VT. These are sort of supplementary evidence for considering ICD, and non-sustained VT and BP fall on exercise, inappropriate BP response on exercise. So what are the other causes of LVH in children? You have a patient who presents to you with ventricular hypertrophy, okay? You have to rule out other things, haven't you? Okay, so obstruction, left ventricular outflow tract obstruction like aortic stenosis and coarctation. Okay, that's ruled out. What else? I don't want the same answers again, please. Okay, so metabolic disorders like Pompe's. Okay, that's fine. Infant of a diabetic mother, good. Renal artery stenosis. Okay, with hypertension, I suppose. What is TA? Sorry, I didn't really understand that abbreviation. We have discussed some of the causes of ventricular hypertrophy just a few slides back. So there are a few syndromes, aren't there? I'm just asking it, the question in a different way. So we know that some syndromes are associated with this, cardiomyopathy, hypertrophic cardiomyopathy. Correct. Williams, Noonan's, Turner's. These should come out very quickly. Muscular dystrophy. Okay. More often associated with dilated cardiomyopathy, to be honest, but there is one neurological disorder that is associated with ventricular hypertrophy. Any ideas? Friedreich's ataxia. Barth syndrome again associated more with DCM. But Friedreich's ataxia, I'm sure now you remember it. So that is another one. And Fabry's disease, which is quite rare, really, but it's another one. Any endocrine problems that can give you LVH? Okay, glycogen metabolic, so glycogen storage. Yes, Cushing's can because of hypertension. Very good. And hyperthyroidism. So these are the various things. So let's see how many we got. What we've got here. Tuberous sclerosis is the other one. So this is one list. We've added some on anyway in our discussion. Okay, a fairly straightforward sort of question. What is the most common causative organism in native valve endocarditis and in prosthetic valve endocarditis? Correct. Strep viridans in native valve and prosthetic valve? Staph. Correct, staph. And it's most often aureus, although it can be coagulase negative staph as well. Fine. So what is a giant coronary artery aneurysm? And how is it treated? Okay, very good. So when you have a coronary artery aneurysm that measures more than 8 millimeters, this is the widely accepted definition. 5 to 8 is large, greater than 8 is giant. And how would you treat it? So often this is in the setting of Kawasaki disease. So I have a patient who's got a giant coronary artery aneurysm. Right, anticoagulation. If the child has any symptoms, then I might want to do a cath on the child. But definitely I want to anticoagulate this child. And depending on the age of the child, if the child is totally asymptomatic, perhaps you can delay the cath till the child is much older. You might want to put the child on a treadmill at that point or whatever. But yes, anticoagulation is the key. So you give warfarin and antiplatelet therapy with aiming for warfarin INRs to be around the 2 to 2.5 mark. Let's see what we say. Correct. So we've got our answer right for that one. Okay, now let's see what you think of this. Okay, the story is this is a 14-year-old. He complains chest pain. To examine him, he has a loud ejection systolic murmur over the left sort of upper sternal border, left, right, both sides really, and he also has a suprasternal trill. Okay, I'm going to play you this angiogram, and you can tell me what condition he has. Okay, any ideas? Give me some observations. What can you see? Start from the very beginning. Okay, yes, supravalvular AS. Right. Now, even before the supravalvular AS, when there is no dye, what can you see? Even before, correct. So you see there is a gross calcification of this area. The aortic valve is calcified and the whole of the ascending aorta is calcified. It moves like a solid structure. Okay. In addition to that, yes, you see the pigtail in the aorta, supravalvular AS, and I can tell you that may not be so clear on this particular angiogram, but there is stenosis of the origin of the left coronary artery. Okay, so now that we know what the findings of this angiogram are, can you tell me what condition this child is likely to have? Okay, Williams. Now, Williams syndrome does not lead to this degree of calcification usually. Yes, it can give you supravalvular AS. I do accept that. But this child does not have the facial features of Williams syndrome. Okay, and there is a family history of problems. See, just straightforward supra AS, familial supra. That's right. Yes, hyperlipidemia. So, but what specific name is this condition likely to have? Is it mild? What is the most common form of hyperlipidemia at this age? Correct. It's fairly severe. So this is familial hypercholesterolemia. Okay. So this child has familial hypercholesterolemia, and this is the homozygous variety, which is severe. Whereas the heterozygous variety is often less severe. So what are the other features apart from this sort of calcification and supravalvular AS and coronary artery stenosis? What are the external features that they can have? Correct. Tendon xanthomas are important. They can have xanthelasma, which is over the eyelids, corneal arthurs. These are all features of deposition. Correct. So how is the condition transmitted? Correct. Autosomal dominant. I gave you the answer. And there's a homozygous and heterozygous form, basically. So the homozygous form is more severe. Now there's a true or false statement. The prognosis for homozygous hypercholesterolemia is good with medical therapy. True or false? False. That's correct. So majority of patients don't live past their third decade, whatever you do. What are the various forms of treatment you can give these patients? Statins and other cholesterol lowering agents. What else? Yeah, the great. So we can put them all together, perhaps pheresis. So they can have plasmapheresis, where you basically remove the cholesterol lipids from the bloodstream. And finally, as a last option, what can they have? They can have liver transplantation. Correct. Fantastic. So these are the various treatment options available, but this is not a very good disease to have. It's a nasty disease to have. Okay. Another very simple question. What is Bazet's formula? Okay. So it's to calculate the corrected QT interval. Okay. Can you tell me what it is? Right. It's QT by root of RR interval. That's correct. Which are the best leads to look at as far as because QT interval can be quite variable and it can be quite difficult to accurately measure. But what are the best leads to look at? Lead 2 is correct, and the right-sided lead is correct. V1, V2, V2. Okay. What are the syndromes associated with prolonged QTC? The names of the syndromes is what I'm looking for, and what is their mode of inheritance? Right? There's Romanov-Ward. Okay. And Jervell-Lange-Nielsen. Okay. Romanov-Ward is, what is the mode of inheritance of the two? Autosomal dominant for Romanov-Ward and Jervell-Lange. What is the other characteristic feature of Jervell-Lange-Nielsen syndrome? Deafness. Right. There are other syndromes like Timothy and Anderson syndromes as well that have been associated with. So a lot of genetic mutations have been identified, and based on these mutations and also the specific ECG and clinical features, long QT syndrome has been classified into several types. So, long QT 1 to 6 is together clubbed as Romano ward and autosomal dominant. The Javel-Lange-Nielsen syndromes are separate. There's JLN 1 and 2. Then you have long QT 7 and 6, which are the Timothy and Anderson syndromes. Okay, so we've discussed all that. Now, this is a true or false question. Long QT 1 and 2 are associated with abnormalities in sodium ion current. Is that true or false? Okay, so what are they associated with? What is the ion current that is the problem? Potassium. Fantastic. So that's correct. Right. I want you to match the following. Long QT1 with the gene. Okay, let's see if you're right. Perfect. Long QT2. We finished long QT1, so we'll come to the second one, long QT2. Perfect again. Long QT3. Yep, SCN5. Okay, what is long QT7 called? Correct, Anderson syndrome. And long QT8 is what is left behind, which is Timothy syndrome. That's very good. So we have another match the following. So this is a mixture of both ion channels and trigger factors. Okay, so we'll say long QT1. What is it? What is the answer to long QT1? Correct. So long QT1 is triggered by activities like swimming, diving, exercise, etc. Okay, long QT3. That's right. It's triggered by sleep. Long QT2. Auditory stimuli. So that's once again correct. Now there's a repetition of long QT3, and this is in relation to the ions. So which ion channel is long QT3 associated with? Sodium. So 1 and 2 are the potassium channels, 3 is the sodium ion channel. Long QT8 is what is left behind, which is the calcium ion channel. Very good. Okay. So what is the characteristic feature of the ECG in patients with Brugada syndrome? Correct. So the characteristic feature is really ST elevation in the right-sided leads, which is V1 and V2, associated with right bundle branch block sometimes. The ST elevation is typical in its morphology. It can be coved or it can be sort of humped, sort of ST elevation. So we'll try and look at some images with it. Oops. Right. So you see how the ST is here. This is normal. So this is a saddle back ST elevation, and this is the coved ST elevation. So if you don't see this on a baseline ECG, what can you do? So you have a patient, right? Exercise. Yeah. So you can drug test these patients. Okay. So you can give them Agmelin or fructanamide, and you see if you can elicit these signs, particularly if there's a strong family history. These drug tests are of borderline usefulness, but still, when you're totally stuck and you have a suspicion, at least if they're negative, maybe you can rest easy. Okay, in Brugada syndrome, tachycardia occurs often during sleep. Is that true or false? Correct. So it is true. So these patients, if you hold them, monitor them, often you find that the tachycardia happens during sleep, and they can sometimes wake up with nightmares, or which could be a reflection of the tachycardia. Beta blockers are strongly indicated in Brugada syndrome. True or false? Okay, so a lot of people have said false. So what is the treatment of choice in Brugada syndrome? Yeah. So no treatment actually, medical therapy actually helps in Brugada. So the treatment of choice is really ICD insertion. So what investigations are required in patients suspected of Brugada syndrome? What are the investigations that you will do? Any answers? ECG, echo, Holter, correct? Yeah. So echo is to look for structural abnormalities. You could do an MRI, particularly if you want to rule out ARVC. Holter and ECG, fine. I'm looking for a couple of basic tests which you have to do if you're suspecting Brugada syndrome. Not necessarily to confirm Brugada, but to rule out other Brugada-like ECG presentations. That's right. Calcium is important. So calcium, potassium electrolytes are very important because hypercalcemia, hyperkalemia can give rise to a Brugada-like appearance. So it might be something that is easily correctable, or it might be something that is a sign of a different underlying problem. And of course, we've already looked at the adrenaline or procainamide challenge test. So I think we've covered all of that now. Okay. So this might be slightly difficult. We'll have to see how we get on because the angio is a little bit truncated. Now these are both in the same patient. It's an adult patient. Obviously, it's a very small catheter. It's gone up there with a bit of difficulty. The question is, what is the diagnosis? Any ideas? Why is it Noonan syndrome? There's no evidence of pulmonary stenosis on that. LP is not really stenotic. Both the PAs, okay, maybe LP is not well profiled. Both the PAs are actually filling up at the same time. I want you to focus on the LV angiogram because the RV angiogram perhaps is not that useful, but focus on the LV angiogram. What do you see that is quite sort of unusual about that LV angiogram? Okay, right. It's not exactly subaortic narrowing, but yes, you get this feeling of the left ventricular outflow tract being a bit small. Now, what usually one of these, this elongated, narrow left ventricular outflow tracts you would see in what condition? What pathology or what abnormality would you see that elongated in an AV canal? Okay, but this is not an AV canal. I can tell you that. And you see that the mitral valve or the left AV valve is totally competent. So there is no evidence of any filling of the LA here. So this is not an AV canal. Okay, but you have this very unusual sort of bulge here. I mean, this is a difficult one, I grant you that, especially because the RV angiogram is, has been truncated for some reason. Hokum. I may accept Hokum as a possible answer, but actually this is a patient with Epstein's anomaly. Okay, now this is a fantastic illustration of, let me just get this to the right point. So here you see this is still the RA. Okay, so the RA is dilated and it's creating this impression into the LV. This is where the right AV group needs to be. This is where the right coronary artery is running, but this is where the actual effective tricuspid valve orifice is. So it's severe Epstein's with severe displacement of the septal leaflet. And actually what you see here as an indentation into the LV is actually the dilated right atrium. It's a slightly tricky one, I grant you that, but perhaps if this right ventricular angiogram had played out much better, you may have been able to diagnose it. But I guess the interesting thing is how the right coronary runs where the AV groove should have been, and where you can see that this is actually where the effective right ventricle begins, whereas this is all the atrialized portion of the right ventricle. Okay, another angiogram. What operation has this patient had? So maybe you can go about it in a methodical fashion. So where is the catheter actually sitting? So this is an angiogram in lateral projection. Fantastic, perfect answer. Well done to you. So this is a patient who's had a Damus case cancel operation, and actually this is a post-Norwood patient, to be honest. It's not a Benzal really. So here you see that the catheter is in the pulmonary artery, but it fills the aorta, which is smaller, and you can see the coronary is coming off that second vessel, which is the aorta. And you can see how the arch actually tapers down. This ascending aortic portion is quite dilated because it's, because of the Damus, and then the arch itself becomes quite small. Now, Norwood patients are quite a significant proportion of them are Norwood require re-intervention for coarctation related issues. And the other long-term problem that they have is left pulmonary artery stenosis, because the Damus compresses on the left pulmonary artery, and a lot of them post-Norwood end up needing left pulmonary artery stenting or some sort of intervention for the left pulmonary artery. So coarctation, LPA, these are two common things post-Norwood which require some attention. So I think that brings me to the end of my quiz today. Good luck for your exams, and I hope you all do well. But we'll catch you next time, next month, same place. Okay, good luck, and bye-bye. You're welcome. Thank you. Okay, guys. Robin, I'm ready to sign out, I think.